Welcome to this week's ECHO Diabetes in the Time of COVID-19 webinar. I'm Dr. Nick Cuttress, Program Director and Pediatric Endocrinologist at Stanford University. Good morning, good afternoon, good evening, wherever you are joining us from. Thanks for joining our program and once again for being a champion for diabetes care in your community. We're grateful for the unrestricted educational grants that we received from Novo Nordisk and Pfizer Inc. that make this program possible. Our goal is to address the urgent needs of patients with type 1 and type 2 diabetes who require complex diabetes treatment in the time of COVID-19 and beyond. We want to empower primary care providers and clinics to safely and effectively manage underserved patients who do not have routine access to diabetes specialty care. Even before the COVID-19 pandemic, outcomes for patients with diabetes were suboptimal. We must recognize that poor outcomes for people with diabetes on the population level do not reflect patient noncompliance, but rather system failure. And as we as providers and healthcare systems must change in our approach on focusing on diabetes outcomes and costs. Data from over 190 million people enrolled in health plans that report HEDIS results to the National Committee of Quality Assurance illustrates system failure for patients with diabetes. In 2018, less than a third of patients with type 1 and type 2 diabetes had A1C of 7% or less. And even more concerning, 30 to 40% of patients had A1Cs greater than 9%. Minimizing hyperglycemia is paramount to reducing diabetes patient risks and vulnerability to infection and complications, including COVID-19. Now is an opportune time to overcome therapeutic inertia and make meaningful systematic changes so that patients are able to achieve glycemic targets. We are living in unprecedented times with COVID-19, but systemic racism and health inequalities have been endemic to the U.S. COVID-19 is making these injustices more clear. We must come together as a medical community and change our practice. We must act. When marked racial disparities in diabetes management exist and prior to COVID-19, we must act. When Black Americans with diabetes with equivalent socioeconomic status as white Americans are less likely to be prescribed intensive insulin management regimens and diabetes technologies and newer medications proven to enhance diabetes outcomes, we must act. We must act and recognize systemic racism and implicit biases that are also occurring within our medical community and our practices today. Our leadership team and faculty are committed to promoting health equity through our programming and combating systemic racism in the U.S. We are committed to action. Today's webinar lecture will address the topic of diabetes disparities during the time of COVID-19 and hope it will provide an opportunity for self-reflection and provokes renewed energy for action and change in our practice. Disparities in diabetes care and technology use is far-reaching. Implicit and explicit bias plays a role in this disparity. Black and Hispanic populations and other vulnerable patients with diabetes with A1Cs greater than 9% are often excluded from diabetes technology. Now is an opportune time to take action to increase access and leverage diabetes technology to help empower your patients. This Wednesday's summer webinar series offered by Diabetes Wise is an example of a resource you could refer your patients and use in your practice as a tool. Today's webinar is entitled Talking Technology CGM Devices During the Time of COVID-19. Another upcoming opportunity to empower and engage your patients with diabetes is the Taking Control of Your Diabetes, or TCOYD, virtual conference on August 1st. Registration is free. Too often, people living with diabetes feel self-isolated with diabetes and lack empowerment to take control of their diabetes. This program is a great resource for both your patients with diabetes and also for providers. Here at Stanford, we're partnering with Project ECHO and other sites across the U.S. on this series. Project ECHO is a globally recognized hub and spoke outreach model developed at the University of New Mexico to reduce disparities and improve health outcomes in patients who otherwise lack routine specialty care. Zoom-based clinics led by multidisciplinary faculty from academic medical centers and community organizations provide providers with education, case-based learning, and expertise that they need to treat patients in their own community. Our presentation agenda will be responding to a question from last week's session, a lecture followed by a submitted case presentation from the community, and then address pre-submitted questions from the audience members during registration. A few housekeeping items: please use the Q&A feature in Zoom to submit questions specific to the topic or presentation. The chat box can be used for communication amongst our attendees and for sharing resources. The webinar is being recorded and will be available for download online in a few weeks after the program on our website. Our website will have additional resources related to diabetes and COVID-19 in the primary care setting. And please complete the evaluation when it's sent to you after completion of each webinar if you want to receive credit. Our ECHO webinar is a safe space for everyone. We have a zero tolerance for language that is discriminatory, disrespectful, racist, sexist, bullying, or offensive. As such, any participant will be removed from the webinar if you engage in any such behavior. Thank you so much for keeping ECHO a safe space for all. We have an exciting series yet to come with excellent and relevant topics. As a reminder, you and other learners are welcome to drop in for any one session. Next week, we'll be featuring diabetes and exercise in the time of COVID-19, and other previously sessions are available on our website on demand. We are fortunate to have a national faculty team from over 12 ECHO programs around the country. I would now like to introduce them. I'm going to stop sharing my screen. And starting with our team at Stanford University and staff, once again, I'm Dr. Nick Kutras. I'm the program director and pediatric endocrinologist. Linda?
Hi, I'm Linda Baer, and I'm the Director of Education for the program, and I also have type 1 diabetes myself.
Marissa?
Hi, I'm Marissa Town, and I am the Program Manager. I'm a nurse and a diabetes educator, and I also have diabetes.
Moving on to our faculty, Marina.
Hi, I'm Marina Bassina. I'm adult endocrinology here at Stanford.
And Magdalena.
Hi, I'm Magdalena Ford, and I'm a nurse practitioner with Stanford's Adult Endocrine team. Nice to see everyone.
And Jessie.
Hi, I'm Jessie Wong, and I'm a diabetes psychologist at Stanford University.
And Rayhan.
There, guys, I'm Rayhan. I'm an adult and pediatric endocrinologist here at Stanford. I also have type 1.
And also in California, Jay.
Hi, everybody. Welcome. Jay Schubert, primary care diabetologist at Touro University, California.
And also in California, representing patient advocacy, Kelly.
Hello, my name is Kelly Close. I have had diabetes for almost 35 years, and I'm editor at diatribe.org.
And Eleni in Florida.
Hi, I'm Eleni Sheehan. I'm a nurse practitioner and diabetes educator at the University of Florida, and I also live with diabetes.
And also in Florida, Ashby.
Hi everyone, I'm Ashby Walker. I'm a medical sociologist here at the University of Florida and the Director for Health Equity Initiatives at the Diabetes Institute.
And over in Hawaii, aloha, Dan.
Good morning, everyone. Good morning from Honolulu. I'm Dan Saltman. I'm a primary care internist and associate clinical professor at the University of Hawaii Medicine Department.
And in New York, Marissa. Right. And in Washington State, Savitha.
Hi, everybody. I'm Savitha Subramanian. I'm an associate professor in the Division of Endocrinology at the University of Washington in Seattle.
And in Nebraska, Leslie.
Hi, I'm Leslie Island. I'm an adult endocrinologist in Omaha at the University of Nebraska Medical Center, and I also have type 1 diabetes.
And in New Jersey, Mary.
Hi, everyone. I'm Mary Bridgman. I'm a clinical pharmacist at Robert Wood Johnson University Hospital and a clinical professor at the School of Pharmacy at Rutgers.
Great. Thank you all for joining once again. And I'm going to just share my screen once more. Great. And we're going to, each week we do some high impact question follow-up. And we had lots of questions questions on CGM and resources and how to reduce cost of CGM. So I'm going to pass it off to Mary and Kelly.
Yeah, it was my pleasure to work with Kelly this week in trying to address this important question, particularly during the time of COVID-19. As far as provider resources go, you can certainly recommend the use of apps, coupons, or a variety of discount programs that exist in this area. I think it's important for providers to realize that programs that we normally think of, apps that we think of for medication cost comparison, like Inside RX or Good RX, really also can be used for kind of price comparing various sensors and monitors in the CGM space as well. We also have some manufacturer discounts and copay assistance programs. Dexcom, for example, has a patient assistance program that includes a voucher for a $60 rebate off of one receiver and one transmitter for the Dexcom G6 device right now. And then they also have a discount program for US customers who've lost their health insurance coverage due to the COVID-19 pandemic. So some important resources through the CGM providers. Also the coverage search app. I had mentioned this on a previous session, but I think it's kind of helpful. The data is updated nightly on drug and CGM coverage. So you can essentially search the product or monitor you're thinking of for your patient, the state that you're in, and the type of insurance that a patient has. And it'll let you know essentially instantaneously if there's a prior auth, a step therapy, or whether that will be covered or not in fact. I'm not usually an advocate for shopping around, but shopping around and encouraging patients to do so, I think makes a lot of sense in this space. There may be some discounts available depending on the pharmacy a patient is utilizing. So Costco may have or has had some plans and opportunities there. Certainly, it's important as providers to be aware of local restrictions or also local programs that may be dependent on your geographic region as well. And then I think my final point for providers is really not to presume that patients wouldn't want to pay out of pocket, but also on the flip side, remember and acknowledge that CGM may in fact may be too expensive for many at this point also. I'm going to turn it over to Kelly, who's going to talk a little bit more about patient resources.
Yeah, thank you so much for the opportunity. And Mary covered so much, such a powerhouse. I love what she said about not presuming, and of course she and I and everyone, all of you, I know too, it being this unprecedented time of 51 million people out of work and all of that is particularly challenging. I just would say, and this slide goes over some of what she went through. We also know that putting, just making sure that you're continuing to talk about people needing more help is really important, and that is how we will get the messages up. We have seen CMS really relax the guidelines, and from what we hear behind the scenes, like even if you think that patients on Medicare don't actually, and that is type 1 and type 2, even if you think they don't qualify for all of the parameters, please still try. At Diatribe, we have diatribe.org/access. More of these pieces are about insulin and other therapies right now than they are about CGM. We're putting a little more up on CGM. There have been big strides in Medicaid, especially from several years ago. But of course, we also know that there's a long way to go on Medicaid. And also we know that the letter of the law isn't always what you experience. And so I just say, like, as a patient, thank you so much for everything that you're trying to do to get CGM to people, even when it is professional CGM, which for Abbott would just be basically trying one sensor. Even if it can give you both, you and your patient, the information about things that should be changed, like therapy, that would be great. We also know that on therapy, there are a lot more tips and tricks that people can use. I would say the patient access programs have gone way further on that side. But I know those are all really long links, but they're all at diatribe.org/access. And thank you so much to our team for helping us so much with this. There are a lot of people with diabetes on the team who are all studying to be in medical school, to be just like all of you. If we can go to the next slide, that just goes through a little bit more on Medicaid. And thank you also, many of you, for the advocacy that you've done. I know we're continuing to work really hard in California in particular. Can we go to the next slide, please? Yeah, those are the basics. Abbott Libre, the Libre 2, being the most affordable option at $109 a month. The cash pay is lower, so if they have a prescription and can go to the counter, we know that this is not everyone. And if you can keep going, I think there is maybe just one or two more slides. Yeah, and this is just the government piece. Us spreading the word also with people, even if they think that they can't afford it, even trying like once will show them a lot about food and exercise and how all of that affects their management. So thank you very much.
Nick, you're muted.
Great, thank you. Thanks again, Kelly, for that. And on our website, we have a resource page with many of the links there for Diatribe. And thank you again, Mary, for preparing those slides as well. And we'll continue to return to this theme weekly in our series. Now we're going to shift to our didactic for this week. And I'd like to introduce Dr. Ashby Walker. It's been my privilege working with her for over the past 2 years in developing the Eco Diabetes program in California and Florida, and want to welcome those from Florida who are joining in. Dr. Walker received her PhD in sociology from Emory University in 2007, and she serves as director for the Health Equity Initiatives at the University of Florida Diabetes Institute. Dr. Walker is an elected member of the American Diabetes Association National Health Disparities Committee and the Chronic Disease and Condition Priority Work Group of 2017 to 2021 Florida State Improvement Plan. Dr. Walker's research as a medical sociologist focuses on type 1 diabetes and the role of social capital plays in determining health outcomes, and she was selected by Diabetes Forecast magazine as People to Know for 2019. Dr. Walker is the recipient of 5 teaching, mentoring, curriculum development awards, and previously served as chair for social sciences at Mars Hills University of North Carolina. It's been a privilege once again working with Dr. Walker, and I'm going to pass off the screen sharing to you, Ashby.
Ashby, you're muted.
Okay, thank you.
There we go.
Thank you so much, Nick, and what a privilege it has been to work as part of a larger community with ECHO and Project ECHO, as we all really strive to improve access for communities, in our case, living with diabetes, who might not otherwise have access to care. So in terms of disclosures, let me just click here. I have no conflicts of interest to disclose related to the presentation today. As Nick mentioned, I do serve on the American Diabetes Association's National Health Disparities Committee, and I've devoted my career to promoting health equity for communities living with diabetes. In terms of the objectives for our time together on this topic, I'm going to provide an overview of disparities in the United States in type 1 and in type 2 diabetes. We're going to consider factors that contribute to racial disparities and ethnic disparities in COVID-19. And finally, we're going to address best practices for supporting vulnerable patients through COVID-19. And I just want to say from the outset how grateful we are today for you joining us. Primary care providers play such a critical role in improving health outcomes for communities living with diabetes. So we thank you for your presence today on the call, and it's my honor to be able to share with you. So what are health disparities? The NIH defines health disparities as differences that exist among specific population groups in the attainment of full health potential that can be measured by differences in things like disease incidence, prevalence, mortality, burden of disease, and other adverse health risks and conditions. So with discussions about health disparities, these are outcomes that are different among groups where we would think outcomes would be similar. You also might hear the phrase social determinants of health. So that's another kind of key concept when we're talking about health disparities. So social determinants of health are independent variables that impact health outcomes being our dependent variable. So social determinants of health and variables that influence health outcomes in the United States would include things like socioeconomic status, race, ethnicity, gender, sexual orientation, age, disability status, and even where someone lives in terms of their geography. All of those are variables that influence outcomes here in the United States. And we had a pre-submitted question last week that was an excellent question. And the question was, what is the difference between a health disparity and health care disparity? Typically speaking, when you focus on health care disparities, you're looking at differences among groups in terms of health insurance coverage, access to healthcare, or healthcare utilization patterns. As a public health professional and someone that focuses on disparities and how to reduce disparities in diabetes, we often take what's called a social ecological model in trying to understand health disparities. And so a social ecological approach takes into account multiple layers of influence when it comes to our health. So there are individual level influences that can influence health outcomes. There are interpersonal differences that might relate to family systems and family dynamics. There are community level variables that may influence health outcomes. And then at the societal and policy level, there are also things that impact at that broad level individuals' health outcomes. Today in our time together, in honor of the Black Lives Matter movement, more of the research that I'm going to focus on is going to be specific to Black communities living with diabetes. We hope today's talk and all of our actual efforts here related to eco-diabetes in a time of COVID can lead to changes that will improve the lives of the communities we serve with diabetes, and in particular, Black communities. To give just a general overview of health disparities in type 1 first and then type 2 diabetes in the United States, to understand the disparities that we are seeing with COVID-19, there has to first be an understanding of systemic disparities that existed prior to COVID-19. So if you look first at type 1 diabetes, we see differences in health outcomes starting in childhood based on socioeconomic status. So one of the most powerful predictors of HbA1c in type 1 diabetes for children is the education level of their parents and also the total household income of their parents. These differences are not just in childhood, they actually persist across the life course in type 1 diabetes. So socioeconomic status and families and individuals who are from lower SES households are more likely to have higher A1C. They're more likely to be hospitalized for very serious diabetes-related complications like DKA. We see the highest rates of morbidity and disease mortality related to SES and type 1 diabetes. But beyond socioeconomic status, we see differences in outcomes based on race and ethnicity. And these differences are independent of SES. And so as was already referenced on our earlier slides today about technology use and diabetes, This is really an area where we see differences in Black communities especially. So we see lower rates of use of CGMs and insulin pumps in type 1 diabetes for Black communities. And this cannot be explained away by SES or differences in coverage. In fact, there's research that consistently demonstrates that even when Black communities with type 1 diabetes have these devices covered, there is an underutilization and underprescription of more aggressive regimens related to insulin and also related to use of technologies. We also see differences in terms of race in children who live with diabetes in the United States. While the risk for having type 1 diabetes is lower for Black children, the risk of dying from diabetes-related complications is twice as high for a Black child as a white child in the United States living with diabetes. In terms of an overview of disparities in type 2 diabetes, in the United States, specific racial and ethnic groups face disproportionate risk for having type 2 diabetes. So non-Hispanic Black, Hispanic, and American Indian communities face higher risk for developing type 2 diabetes, and this persist even when individuals have what we would consider as a medical community a normal BMI. Also, there are differences in socioeconomic status in terms of who is more likely to develop type 2 diabetes, with lower income communities facing higher risk for developing type 2. And when we look at outcomes in type 2 diabetes, non-Hispanic Black communities face disproportionate risk in terms of disease complications related to disease morbidity and mortality. So to frame the discussion of racial disparities in COVID-19, we have to first acknowledge that there are pervasive health disparities in the United States. And COVID-19 and the patterns that we're seeing with COVID-19 are revealing what is long, widespread, systemic racial differences in health outcomes in the United States. So when we look at data on race and ethnicity in COVID-19, I do want to say from the outset that one of the challenges about reporting is that we have inconsistent, sometimes, data on race and ethnicity in topics related to COVID. So if we look at data on who is being tested for COVID in the United States, if we look at data on who is being hospitalized for COVID-related complications, if we look at data on who has a confirmed case of COVID and then who is dying from COVID, in many cases, we have inconsistent reporting. And there's a really great website, and I just want to let you know, anytime I reference a website or any type of resource, I have it embedded right here in the PowerPoint. And this is available to you after today on demand through Stanford's website. So Johns Hopkins University has an excellent website on transparency and reporting related to race and ethnicity. So even though we have kind of inconsistent pieces of data about race and ethnicity, from the look that we do have that is consistent, we know that race and ethnicity matters when it comes to who is at risk for getting COVID, who is most at risk for being hospitalized, and then ultimately what we see in terms of death rates from COVID. So looking at CDC data from March through mid-June, we know that there are differences in terms of who is being hospitalized for serious COVID-related health factors. So we see that there is a 4 to 5 times higher chance of being hospitalized in the United States for COVID-related complications for non-Hispanic, Black, Hispanic, and American Indian communities. When we look at who is dying from COVID, there are drastic differences based on race and ethnicity. So here again, this is data from the CDC going from March through mid-June. We see that Black communities in particular and Hispanic communities across age brackets are facing higher risk from dying from COVID-related complications. Why do we see these patterns of difference and disparities in COVID-19 based on race and ethnicity? We already have widespread health disparities in the United States. And so COVID is revealing patterns of existing health disparities that existed prior to COVID-19. Black communities have higher infant mortality rates, maternal health risk, and shorter life expectancy when you compare them to their white counterparts. Black adults are 1.5 times less likely to have health insurance than white adults. We also have a pronounced stratification of our workforce. So when you look at who essential workers are, and when you look at who is going to work and who doesn't have the freedom to stay at home right now, there are racial and ethnic differences. So Black and Hispanic adults make up the majority of our essential workforce in the United States. And this is especially true with food and agriculture industries and residential facility services. So less than 30% of non-Hispanic Black and Hispanic communities have been able to work from home during COVID, compared to greater than 60% of white communities. So when you look at who is at risk in terms of going into the public and having to interface with other people right now, there are racial differences in risk. We also have long-standing patterns of residential stratification and segregation in the United States. So where people live is still stratified by race in the United States, and especially low-income Black communities tend to live in neighborhoods that have higher environmental toxins and exposures like pollution and lead-based paint that put somebody at greater risk for trying to survive a disease like COVID-19. We also see differences in terms of multi-generational households. So if you look at white households and you compare white households on average with Hispanic and non-Hispanic Black households, Hispanic and non-Hispanic Black households are more likely to have multiple generations living under one roof. So multi-generational households, again, produce more risk when you have younger people exposing older generations to COVID. And then finally, beyond COVID, there are differences in risk for poverty and food insecurity in the United States. So Black families are 2.5 times more likely to experience food insecurity, and this is prior to COVID. So when you add COVID as a pandemic on top of these patterns that we see and that have persisted for years and years, then we see disparate outcomes in COVID-19. When we consider your patients who have diabetes, who are at risk right now in COVID-19 because of diabetes, and then additionally because of race and ethnic minority status, I'm highlighting here a graphic that comes up a lot. It's in the middle of your screen, and it's 42 factors that affect blood glucose. And this graphic is used commonly in talks where we're raising awareness with the public and healthcare providers about how many things impact blood glucose and someone's ability to really thrive with diabetes. Even when someone is doing everything within their power, it is really hard to achieve targets that have been set forth for HbA1c management. And so you see the 42 factors that affect blood glucose, and there are biological factors and environmental factors, stress, a lack of sleep, sleep disruption, the type of medication someone's on. What I would want us to do today is to pause and think about how much more A1C or blood glucose is impacted for someone who is Black, who is trying to live with all of the structural inequalities that we referenced on earlier slides. So in addition to these 42 factors that we point out commonly that affect blood glucose, if you think about systemic inequality in the United States, differences in the workforce, differences in terms of risk and exposures to environmental toxins, how much more challenging is it for Black communities right now to navigate the COVID-19 pandemic? And in fact, there is research that's been done at the University of Florida, and I want to call attention to Dr. Connie Mulligan. I have a link to her faculty bio here, and she has looked at epigenetics and biocultural differences in terms of how communities, for example, Black communities, have higher risk for disease morbidity and mortality related to hypertension and diabetes, as it relates to discrimination. So what do? All of us have some circle of influence that we can do something to try to address racial disparities and disparities in COVID-19, especially as we serve our communities in primary care settings who live with diabetes. Number one, it is essential to emphasize protective measures to reduce COVID risks. So for your patients who you see talking about how to minimize risk when it comes to COVID, face mask in particular, and how to navigate in a multi-generational household and minimize risk. So the CDC has specific guidance that they've given that will help assist you with thinking about how to address risk with patients who are from racial and ethnic minority communities, and also how to think about addressing protection during a time of COVID for people who live in multi-generational households. So the link to those CDC guidelines is right there embedded in the PowerPoint. Number two, screen for food insecurity and develop local resource guides. Food insecurity and families who are suffering from food insecurity, we are at epic rates of food insecurity risk right now. There is a 2-item validated screening that you could implement in your clinic settings for all of your incoming patients to be able to identify risk, and then also to refer to local food resources. And so we have developed resource guides for PCPs, for communities living with diabetes in a time of COVID. I've included the link here to the University of Florida Eco Diabetes landing page, and you can find links and templates for resource guides. Now, the local food resource guides you will have to develop because that will be unique to your area. And I just want to say, if you're a provider and you're somewhere and you think, I don't have the time to make a resource guide for communities living with diabetes right now that's specific to my area, I would encourage you to reach out to us. There are many, many college programs. I have students who are doing their MPH work all over the United States in our online MPH program here at UF that needs special projects. So we could likely connect you with someone who could help you develop a resource guide for your area. There are students who are eager to help and to assist here. Have a sick plan in place. Preemptively talk about sick plan management for your patients with diabetes and COVID. We had a great session already by Eleni Sheehan, who's on this panel, who talked about how to develop a sick plan management with your patients with diabetes. I have that talk embedded here under number 3. How do we address racial disparities in diabetes? So beyond COVID, tackling racial disparities is a question that we have to grapple with and continue to grapple with. Avoid narratives that place individual level blame for disparities in health outcomes. So we have seen there are many social, contextual, societal level issues that contribute to someone's health outcomes. And so avoiding a narrative or a description about health disparities that is self-blaming or lays the onus of disparities on a person. Number 2, strive for diversity in your staff and seek stakeholder engagement. When we look at endocrinologists in the United States as a workforce, over 95% of endocrinologists are non-Hispanic white. When we look at registered dietitians in the United States, over 98% are non-Hispanic white. It is imperative when we think about serving communities who live with diabetes, and especially serving communities who are non-white, that our workforce reflects that diversity and that we have stakeholder engagement in every level of care. I'm going to give a shout out to actually an Instagram account. It's called Women of Color Diabetes, and I have at WOC Diabetes here just to show an example of how a community has spearheaded representation in diabetes for diverse communities. Recognize, number 3, recognize culturally sensitive and inclusive approaches to nutrition guidance in diabetes that includes the concept of food voice. So when we talk about diabetes management, A central part of diabetes management involves people's foods that they eat. What we eat, the foods we like and prefer, is deeply connected to who we are culturally. It's how we celebrate every major life event from birth till death. And so when you think about giving food guidance to communities, take into consideration food voice and foods that are intrinsically part of somebody's identity socially shouldn't be denigrated in any way. Finally, and this is something that you have such an opportunity to keep thinking about during the seminar series, work to increase technology use, like the use of CGMs for Black communities living with type 1 diabetes and type 2 diabetes. Oftentimes we talk about coverage as one of the biggest barriers for CGMs, and undoubtedly, especially in this time of COVID, coverage and the cost of a CGM is going to be a barrier for many patients. But collectively, we can raise our voices to payers about the value of CGMs and the value of covering CGMs. I also want to point out that in research we have done here, and we collaborated on this research with Stanford, we presented it at the ADA, and we are happy to share this poster. When we did focus groups with adults who face significant health risk, who live with type 1 diabetes, who had been hospitalized in the last year for DKA, and who were diverse, when we asked them what the greatest barriers are that they face in utilizing technologies like CGM, the most commonly cited barrier was not coverage, but provider level barriers. So a provider thinking that they weren't in, quote, good enough control to have a CGM, or that they couldn't handle a technology. And so when patients seek these technologies, we have to make sure that they don't encounter a barrier at the provider level that even lets them get to the coverage level to even know if they can utilize these technologies. So there's so many things in terms of racial inequality that feel insurmountable, but diabetes technologies are a modifiable variable. And if we can focus on this as a community and in increasing the use of CGMs for the communities that we serve, we will go a long way with reducing health disparities in both type 1 and type 2 diabetes. I'm going to give just some recommendations for readings. As a professor who teaches about health disparities, and I teach MD, MPH students, these readers touch on very different areas, and I've given the actual full VIN number underneath it so you can access easily to buy them. But the first one would be The Health Gap. This is a look at health disparities from an international perspective. So looking at international data, looking at different countries and health disparities in different countries. We have such a beautifully international audience on our calls each week. So this would be a really good book if you're interested in understanding how a developed nation like the United States continues to have such pronounced health disparities. I'm going to also call attention to a book called The New Jim Crow. If you want to better understand systemic differences in our prison system that start in our juvenile justice system that are specific in terms of creating disadvantage for Black communities, this would be a great book. Mama Might Be Better Off Dead is a great reader about type 2 diabetes, multi-generational type 2 diabetes, and social immobility in the United States. And then finally, A Black Man in a White Coat is an excellent firsthand account of what it's like to be a Black American as a physician in a culture and in a world where most physicians are white. In conclusion, I'm going to share a quote that was in an article that was published recently in The Lancet. The COVID-19 pandemic will come to an end eventually, but what is needed afterwards is a renewed focus to ensure that health is not a byproduct of privilege. Thank you so much for your time.
Thank you so much, Ashby, for that fantastic presentation. And we're going to open it up for questions now. And there's faculty responding to Q&A. And if you have additional questions for Ashby, please go ahead and type them into the Q&A box, and we can try to bring them live now. There was a question that came up on international care, comparing practice in Mexico and in the U.S. and even within the U.S. that we have excellent guidelines from the American Diabetes Associations and other organizations, but the implementation and the system failure to allow those to be implemented is pronounced. And Mexico, they also have the Mexican Diabetes Federation with excellent guides as well. But once again, be able to implement those to all populations, as Dr. Walker mentioned, is often challenging. And any other questions that came up that faculty addressed that would want to bring up to Dr. Walker?
Yeah, Nick, we had a question. What is the influence of SES and occupational disparities on the treatment of diabetes and COVID-19?
So if I understand the question, what is the role that SES is playing in disparities that we're seeing, because we focus maybe more on race today?
I think that was the crux of the question, Ashby, and great talk, by the way.
Thank you. We don't have great data available to me that I could actually answer this question with the data I would like to have. So the data that I presented to you was on race and ethnicity in terms of hospitalizations and death. I don't have comparable data looking at that then delineated by SES. But I will say in general, when you look at research on disparities related to race, these disparities persist independent of SES. So we will see elevated risk, for example, for Black communities who are affluent as well. So we will, I know as the pandemic unfolds and we have more access to more data, we're going to get a better understanding of SES and health outcomes and how those all intersect.
And then maybe one final question before we move on to our case presentation, and this can be to you, Ashby, from the research perspective, also just from the clinical perspective to other faculty members with regard to foot wounds and health disparities in treatment of diabetic foot wounds. Anyone want to comment on that?
I can mention that there has been a good amount of research showing that the screening for secondary complications in diabetes, there have been disparities shown in that practice based on race while controlling for SES. So I can't speak necessarily to the treatment side, but at least for the early screenings and detection, that there are disparities and largely based on provider practices.
Thank you, Jesse. Address one of the pre-submitted questions. With diabetes, there's an overlap with vitamin D deficiency. So many of you are already prescribing vitamin D for patients with diabetes. And a new consensus statement came out on vitamin D. So one of the questions was, what is the role of vitamin D in the prevention or treatment of COVID-19? Mary, do you want to take this?
Yeah, absolutely. And, of course, we have no dietary supplement that will cure or prevent COVID-19, just to be clear. And I think it's an opportunity to really remind our patients that taking too much of certain supplements, as we've even sort of described in this case, can potentially be associated with more harm than good. That being said, in the absence of a specific treatment or a vaccine, we are seeing patients turn to dietary supplements that have this track record of immune support. So zinc and vitamin C and vitamin D. I've got questions from patients and friends and family members alike during this time. Again, just to sort of focus on the role of vitamin D, as we know, the classic actions associated with vitamin D are to promote calcium homeostasis and bone health. But of course, during the time of COVID, the immunologic immunologic effects of vitamin D really have increasingly garnered some interest here. It's recognized that vitamin D has numerous effects on cells within the immune system. It inhibits B cell proliferation and differentiation, as well as immunoglobulin secretion. It suppresses T cell proliferation and decreases inflammatory cytokines, and may actually increase production of anti-inflammatory cytokines as well. Earlier meta-analyses during non-COVID times with regards to influences of vitamin D on respiratory tract infections have concluded or found that vitamin D supplementation may be associated with a reduced risk of respiratory tract infections. So that literature was sort of jumped on by a number of people early on in the pandemic. We do have some limited data from observational studies suggesting this association between vitamin D levels and severity of COVID-19 illness, that people with vitamin D deficiency may be at higher risk of more severe disease. Now, these are, of course, epidemiologic studies, and the associations may have to do more with ethnicity or age or institutionalization or just other confounders as opposed to a causality due to low vitamin D levels. But it's certainly worth mentioning because I'm sure we've all seen that in the literature. At this point, again, we have no evidence that supplementation helps prevent or treat COVID-19 at present. But if we go to the next slide, and I'll share the link in the chat as well, we've got this joint guidance statement. We recently, just in the past week or so, we've had 6 medical societies from around the world providing a consensus guidance on the impact of COVID-19 on vitamin D. And again, the link is shared now. It's a very brief document, and it just really highlights the fact that we should be encouraging our patients to get 15 to 30 minutes of direct sunlight exposure, of course, avoiding sunburn if possible, consuming vitamin D fortified foods or nutritional supplementation, and encouraging a vitamin D intake between 400 and 1,000 international units for most adults aged 19 years or older, of course, depending on age and sex. So thought that was kind of timely and wanted to just share that for your information.